Oh, it's we have a wonderful presentation today about cancer-related trauma, and we have two fantastic speakers, Christina Bach and Sophia Smith, who is, I can say, one of our own. She is not only a fellow survivor, but she's also has been a board member for years and years. Sophia has a master's in social work and a PhD, and is an associate professor at the Duke School of Nursing in Chapel Hill. Christina has so many titles next to her name. I'm going to just say she's well qualified to give this talk. She's also a licensed clinical social worker specializing in oncology. She's a content editor and writer for OncoLink, and I'm sure there's more on her resume that I could list here. But we're so pleased to have them. I think Christina is going to speak first. Sophia, were you going to do a better intro than I did? And
You,
Sophia,
you hit all the highlights. However, you left off that Christina volunteers with her therapy dog, Huckleberry.
oh,
I
okay.
had to mention that because I love that name.
Well, and he's here. That's him on the chair behind me.
Aw.
And my other two rescue beagles are also here. Eugene and Dennis are hanging out. So you may see them in the background. So thank you, Sophia, for the plug for my volunteer work, which I love, and I'm so honored to be able to do. We work a lot with cancer patients who are hospitalized and do a lot of visits. So and Huck is just a magical light for them. I was over on the floor yesterday, and I didn't have him with me, and it felt strange to be there without him. So,
Aw.
but I want to thank Sophia and for one, so just a little background for everybody. Sophia and I were at a conference together in June, and she came to a talk that I gave with another colleague about trauma-informed care, which has really become in this sort of second phase of my career, my mid-career sort of phase, my bread and butter. I absolutely love this space. It's given me a real framework for what I think I've been struggling to define in my social work career, and I'm very excited to bring it to you. I do want to just level set and say I have not done this for survivors before. I've trained hundreds of healthcare providers in trauma-informed care. But this is my first time really bringing this piece to patients and survivors. And so I'm anxious for your feedback. I hope you will feel safe, and I'm giving permission for you to ask questions, be vibrant in the chat, come off mute and ask questions. And I'm really just, again, Sophia, thank you so much for inviting me to be here today. I'm going to go ahead and share my slides. And again, I don't know how much I can see with Zoom. It's very funny. When I am, excuse me, I of course also ate up some trail mix, and now I'm regretting because it's not being very lovely. Okay, so I don't know how much of you guys I can see on the screen. So, Sophia, if anything pops up in the chat, will you or Aaron or anybody let me know, and I'll be happy to talk about what's on your mind as I'm speaking.
I got you, Christina.
Thank you, Sophia. And I did ask Sophia if she would be so kind as to do this talk with me, because she is such an incredible pillar of research in this space, especially in post-traumatic stress disorder in cancer patients and caregivers. And I do also want to say that I am a cancer caregiver myself. My mom is a 4-year breast cancer survivor. And certainly going through that experience with her, my mom, was different than all the time I've spent with patients in the past 25 years. And certainly something that has changed the way that I work as a social worker. And I think that is a really good example of post-traumatic growth, which I'm going to talk about a bit today. Okay. So, just a little level setting. As we begin this conversation, it's important for us to create a safe space together. I want to be sure that we're honoring everyone's experience and understanding that some of you may not want to share, some of you may want to share, and really respecting each other and the rapport that you clearly have with each other, which I'm so glad I got to see for the first 10 minutes or so of the meeting today, that we're respecting each other's privacy and keeping things in this space. I also want to say that for many, the experience of cancer can activate old wounds, trigger difficult memories, or even re-traumatize you. And cancer itself, its treatment, and of course, its survival is also often traumatic. Survivorship is a tricky space. It can open the door to healing and post-traumatic growth, but it also can feel like you've been set free. A lot of patients talk to me about feeling like they've been put in a boat and said, have a nice life after they finish treatment, and that they have all of these feelings, feel very detached, feel very abandoned, and that in itself can be a very traumatic experience. I do want to say that experiencing trauma or PTSD after cancer is not in any way, shape, or form a sign of weakness. It is 100% normal. I think Sophia and I would both say it is way more common than we think, and we need to start giving ourselves permission to call it what it is. And I'm hopefully going to talk to you a little bit about why I think we have some barriers to calling these experiences that we have as cancer patients or as cancer caregivers traumas. I think that by acknowledging this openly, we can help to reduce the stigma and remind each other that we are not alone in this experience. So I am a self-identified internet junkie, social media junkie. Everybody knows 10 o'clock at night is Christina's TikTok time. This actually came from Instagram, and I was doing a little search, and I really loved this quote. Cancer is the most traumatic experience I have ever had, and yet, before I was diagnosed, it never crossed my mind that it would be considered trauma. And again, I do want to say, some of you may consider it a trauma, and some of you may not, and that is perfectly fine. We all have different spaces. As I like to say, it is not the suffering Olympics. But I do want to at least give you guys permission to think about how this experience of going through cancer treatment, and for many of you, that was many, many years ago. And somebody said, when you guys were, I call it pre-gaming, and not expecting this. And I'm wondering if that whole experience of living with a life-threatening diagnosis, going through treatment so many years, if you thought about, was I ever going to get to be 78 years old? And is that the change that is? And what is it like for you then to live in a space that maybe you anticipated not surviving your cancer, but you have? And how does that feel different for you as well? So let's take a little bit of time to talk about trauma. And I did use this image purposefully because trauma is intrinsically linked to things that are happening in our brain. We could have an entire session on what happens in various parts of the brain as a result of trauma exposures, but we're not going to do that today. If you want me to come back and do that another time, we can. But I'm going to take a little higher level look at what trauma is. Trauma results from a stressful event or a series of events that an individual believes is physically or emotionally harmful or life-threatening. What I love about that statement is it gives you the ability to define what is traumatic for you. So again, what feels traumatic for you might not be for someone else. It can depend on things like other life experiences, identity, culture, religion, power dynamics that are influencing the situation at that time. And trauma can come from that one event, excuse me, or build up over time for many experiences. We see that a lot in healthcare providers who are experiencing post-traumatic stress as a result of providing care to so many patients who have negative outcomes over many, many years. I can't tell you in the 25 plus years I've been an oncology patient, how many patients I have worked with who have died. Hundreds, that may be thousands. Those build up over time, those collective losses. And I think about a lot of my patients very, I mean, like I can recall that some from 25 years ago and actual conversations what we have. They have it, you all have an impact on us as well. But again, your experiences as cancer patients and cancer survivors over the years can build up over time, and that can affect how trauma is happening for you. And trauma can last a long time, and it impacts our mental, emotional, physical, social, and spiritual well-being and our everyday function. There is a really, I actually want to go back to this slide. There's a physician that works here in Philadelphia, Dr. Sandra Bloom. I forgot to say, I'm coming to you from Philadelphia, now you know. And she says that trauma is when a person's internal resources are overwhelmed by external circumstances. And what I love about that quote is that Dr. Bloom assumes that we do have internal resources, again, back in our brains and our bodies. We also have external resources, the people who support us, privileges for me. My external resources are 100% these cute beagles who support me every day. But what she says is when we have a trauma, our internal and external supports cannot deal with what is happening around us. So our ability to cope is stretched beyond our limits. There's 3 E's of trauma. And trauma is 1, the event or the series of events. So for the purposes of explaining this, I'm going to use the example of a car accident. That's the event. Or perhaps repeated or chronic experiences might be things like child abuse, systemic racism, or prolonged or repeated cancer treatment after recurrence. Again, not all stressful events are traumatic. And if it is traumatic, it is often shaped by experience and the effects, the other 2 E's. The experience is how we experience what has happened to us. Again, 2 people may go through the same thing, but we're going to experience it very differently. Like those personal factors, when it happened, our age, other things that have gone on in our lives, the supports we have around us, our identity, who we are, influences how we experience the event. So for example, let's say 2 patients undergo having a portacath put in for treatment. One of those patients feels very cared for, supported, has no problems, her pain is managed, but the other one feels terrified, powerless, is nervous about having this external device essentially in her body for a period of time. So only that person may experience that same thing as traumatic. And finally, effects. These can be short term, so things that happen in the hours to weeks right after a trauma, to long term, which is months to years after, or late effects, which can emerge years later, often related to unresolved trauma. And where do we talk about side effects just like that? Short term, long term, and late effects in cancer care. So that was a very interesting way for me to draw that connection between cancer care and trauma care, and that how we experience those things over periods of time. So again, let's go back to my example of a car accident. Short-term side effects may be injuries, shock, fear, disbelief, nightmares, avoiding driving or riding in a car, feeling distracted or trouble concentrating. Long-term could be things like chronic pain, anxiety about riding in cars, avoiding highways, busy roads, or traveling in the same place where the accident happened. And those late effects could be traumatic stress that is triggered by hearing or seeing a crash nearby, withdrawing from activities that require car travel. And again, that's going to have something that happens years after the event. Any questions so far? Okay, I'm going to assume that means I'm doing a good job. At the top of this infographic, and again, this is something I found on Instagram, I think this image does a really good job of breaking down what I think most of us would, when we think about trauma, identify. Things like being the victim of abuse or assault, natural disasters, war, or other large-scale crises, or being in an accident or a victim of a crime. I think all of us would agree, and when we think about trauma, we think about oftentimes those 3 things, totally common and normal. What I loved about this infographic is that it really normalized the things on the bottom of the slide as also potentially traumatic for the individual who might be going through them, including things like scary medical procedures or a life-changing diagnosis, being a long-term caregiver of someone with a serious illness, experiencing a major mental health episode or a panic attack. And I will remember being with a patient when she had her first, and unfortunately not her last panic attack. And that was incredibly traumatizing for her in that moment. And so I wanted to, again, really give us the language to normalize that some of these happen and may deeply impact the people that we are interacting with every day. By understanding trauma in its many forms, we can have greater empathy, sensitivity, and apply a trauma-informed lens to our own lifestyle. I wanted to take a minute to introduce you guys, maybe some of you have heard of this before, to this concept of adverse childhood experiences, or ACEs. And these are things that might have happened to some of us during our childhood. It could include things like physical, emotional, or sexual abuse, being neglected by parents or other caregivers, household dysfunction, parental substance abuse, the loss or death of a parent, and community violence. Why are these things important? Because they stay with us. And ACEs impact our physical and mental health for a long, long time. Research has shown that those who've experienced ACEs are more at risk for heart disease, obesity, substance use and abuse, and mental health issues. And some research suggests that ACEs also impact our life expectancy. The more ACEs you've experienced can equal a higher risk for health issues. So this was originally studied in the late 1990s, 1998. And then the study was expanded in 2012, and they expanded the definition of ACEs to include things like witnessing violence, discrimination, neighborhood experiences, and bullying. And what's really important is that for those who experience 4 or more ACEs, we tend to think of them at a higher risk for adult trauma as a result of these ACEs. So let's remember that we bring those experiences into the exam rooms, into therapy sessions, when we're in the hospital getting care, and that it's important that sometimes we may not know that those ACEs are something that are really impacting our abilities to interact with our healthcare teams and to help ourselves regulate and feel safe when we're accessing healthcare. Sorry, I had too many slides and I have, like, of course, my notes. So want to make sure I'm getting to everything. And Sophia, I'm hoping that you might chime in a little bit here. I'm not sure, Anna, is drawing on the screen, which is fine with me. It's a little distracting. No
Okay.
worries, Anna.
Yeah, I'm happy to chime in.
Okay, great. So I did want to just take a moment to honor and recognize that cancer for many of individuals, and maybe for some of you in this call, is a traumatic event. Oftentimes it's sudden, life-threatening, and it's always life-changing, life-altering. I've worked with a lot of blood cancer patients over the course of my career. I'm very, very lucky to work very closely with a myeloma support group here in Philadelphia. And I am always shook myself by the suddenness and the unexpectedness of their diagnosis for many of them. One of my clients in that group tells the story of how he was down the shore, down the Jersey Shore, as we say here in Philly, down the shore, and was body surfing with his son and kind of took a bad wave and hurt his neck and, went to urgent care, went to the doctor, wasn't getting better. And finally got a scan, and he tells the experience. They came in, by the way, this was 15 years ago, and this is still how he's able to tell this story. They came in and told me my bones looked moth-eaten and that I had myeloma, a disease I had never heard of before.
Yeah.
And that was so incredibly sudden, and all of a sudden changed his life in that small minute that he was told that just because he went down the shore with his son that day. What we also know is that you may experience, and this is one thing I absolutely observed, and Sophia, I'm sure you can say things about this, the loss of control.
Mhm.
Whether it's I can't control my schedule because I have to get to this doctor appointment and they keep changing it, or it's at this time and I'm there for 7 hours instead of 2 hours or whatever. Those little nuggets of control are so important in our lives in terms of giving us control of our lives, our agency, and our autonomy. We also may experience things like threats to who we are, whether it's mother, father, sister, brother, uncle, cousin, worker, parent, survivor, all of those things. What does it mean when we have cancer come into our lives? Our quality of life is affected, our bodies change, whether it's hair loss, whether it's the scars, whether it's weight gain, weight loss. We feel
The-
like we are betrayed by our bodies. And then, of course, the sense of mortality. Sophia, go ahead.
No, I was just going to add, so Christina, with our tribe, many of us have had more than one cancer.
Yeah,
So, and the traumas are repeated.
of
So we
course.
have the original Hodgkin's diagnosis, then we have the trauma related to the treatment, and the treatment can be multiple. It can be chemo, radiation, surgery, all
Yep.
the above. So
Hmm.
we've got all those traumas. And then many years later, usually like 20 years later, we'll get a late effect
Right.
from the radiation they gave us or one of the chemo drugs. And now we've got a second cancer, a
Yep.
breast cancer, a colon cancer, or most of us, a lot of us, are having cardiac issues from the chest radiation.
Mhm.
That's the biggest late effect. So you can see, the trauma isn't just at initial diagnosis, it's persistent.
Yeah.
And because of that, in my work, which I'll talk about in a little bit, is we're seeing those PTSD symptoms persist. They don't
Mhm.
go away after the original diagnosis, they persist many years later. And why do they persist? Well, because of the multiple traumas, but also because of the lack of awareness among our clinicians to ask the questions or
Correct.
to recognize that what this survivor is describing is PTSD, cancer related PTSD. And as you said earlier, many of us have other traumas. Um, and that preceded the cancer. So that's what I wanted to add.
Thank
I
you.
can
And
keep I can keep
I'm
talking too.
no, I'm so glad that you brought up also just the recurrent nature,
Mhm.
right? Similar to that, recurrent nature of cancer, these traumas come up just as much as they do. And I know and Sophia and Aaron will tell you guys when I first was talking to them about coming to this group, I told them the story of a friend of mine from high school who was diagnosed when we were 17 with Hodgkin's disease and was treated this was mid 1980s. Was treated, um, had a really rough time. Of course, what it's like to go through that as a 17-year-old is another layer, another adverse childhood experience. Survived only to be diagnosed with breast cancer in her late 30s, and then to have cardiac issues, and then to be diagnosed with lung cancer, which ultimately caused her death 2 years ago. And so that ongoing and just kind of waiting, when is the next thing coming is a very, very difficult space to live in and to not be able to get away from, which we recognize as well.
I just
So
had a quick,
Christina, oh,
Mhm.
go
Go
ahead,
ahead.
Erin.
no, I just for both of you, but before we go any further, you've used the term unresolved trauma.
Mhm.
Is there such a thing as resolved trauma? I'm not getting it. Especially after what Sophia just said. How do you end up with resolved trauma when, I mean, that's my question is what
I'm
what's
not
the
sure if
difference?
we should use the binary necessarily resolved versus unresolved. I think that there are many folks who compartmentalize trauma or apply techniques of post-traumatic growth to integrate their trauma experiences into their lives and to understand how they affect their identity and who they are going forward. Just like I don't think we ever actually fully grieve and get closure when we've had a loss in our lives, I don't know that we can actually have a resolved trauma. Does that help, Erin?
I,
Yes,
it,
there's just a word that you had used a couple of times, and I thought, geez, I don't think I even know what resolved anything is anymore.
Mm. I think
Thank
Christina,
that's
you.
often used in the literature. Go ahead, Sophia. Sorry.
Christina, my friend Andre has a couple really good chat entries in there I just want to bring up. And I know you touched on racism earlier, and his comments are that there are also race and class trauma twos
100%.
that precede or coincide with the cancer trauma, plus
Absolutely.
gender, sexuality, all of the above. I wonder if
And
you could just say a couple of words about that.
yeah, Andre, thank you so much for those comments. It's so important for us to recognize that, you know, a lot of research in cancer care alone is done in cis, white, heteronormative spaces, right? So we're thinking that all of these things we know about cancer apply to all cancer patients, and they don't. And so we really do need to be taking into account the fact that maybe we are also re-traumatizing patients because we think this is the way that it should be, but really we need to be looking more at how things like the intersectionality of different parts of our identity affect our cancer experience. We also know that folks of different colors, different races, different ages are diagnosed disproportionately and oftentimes at later stages with their cancer treatment. We also know they have less access to the best care, whether it's because of financial issues related to insurance, whether it's because they live in rural spaces, whether it's because they're too old to get XYZ treatment because maybe the benefits are outweighed by the risk. So there's a lot of nuance there into how all of those points can impact our ability to actually navigate what it's like to be a person with cancer.
Thank you.
All right. In the presence of time, I'm going to keep going. And Erin, I don't know if there's any way if we can erase the screen because I'm having a little bit of a hard time. Let's see. Oh, I did it. Never mind. And I'm sorry to the person who.
No problem.
There we go. Okay. So I was trying to think of some spaces, and Sophia, I think will back me up that these are a lot of the symptoms we associate with trauma and post-traumatic stress and cancer.
This
And
is excellent. I just looked through your list. Yeah, love it.
I was like, so what does that look like? What might they look like for all of you? And I would love to hear, I'd love to see in the chat box if any of you have experienced these things, but ever thought they were a trauma, potentially a trauma response. So like, have you thought, what if the cancer comes back? Is this my lymph nodes feeling swollen? My favorite one that I do myself is I have a headache, it must be a brain tumor. So when do those intrusive thoughts come in? Do you have those? And have you thought, maybe I'm having those because I went through a trauma? When it comes to avoidance, that might include things like skipping follow-up care, scans, or labs as they're ordered. And again, I know we talk a lot in the psycho-oncology space about scanxiety. I actually think scanxiety is a trauma response.
I do too.
And yeah,
100%.
I'm working on that talk next, Sophia.
Okay, awesome.
Also things like hypervigilance. And I have to give credit where credit's due to some of my AYA friends who are so funny with their hypervigilance on Instagram and have really funny memes and posts that they do about how often their relationship with my chart and over checking symptoms, looking for labs all the time. I had a friend who went through lymphoma treatment and she would get a scan done and be sitting in the waiting room to go see her doctor, but read the results before she went and saw the doctor. And I think that was a protective thing so that she could prepare herself for what might be coming. But also, it was potentially troubling because she didn't really know what she was reading. So, how do we find a space where we can have access and where we want to be involved in our medical care, in our symptoms, but also make sure we're getting the right information. Sleep disturbances, I think, are tough. I think a lot of us have sleep disturbances at our baseline because we just aren't a well sleeping society. We're hyperstimulated, I think, all the time. But sleep disturbances are definitely things that come up for cancer patients and cancer survivors, whether that's insomnia, the inability to sleep, hypersomnia, sleeping a lot, nightmares, trauma, and this trauma associated sleep disorders. Then irritability. Okay, I understand a lot of us are irritable at different times at baseline for different reasons. I am definitely irritable when my Philly sports teams are not winning. That is very different, though, than a trauma-related irritability, which might include things like loss of temper, feeling agitated, feeling like you can't regulate yourself, getting defensive, feeling also what I like to call, or what they call in the business, decision paralysis, where you know you need to do something, but you just can't do it. And the idea of doing it also just pisses you off. You don't want to do it. That's irritability. And then finally, loss of interest in activity. So maybe you're avoiding things. There's nothing like going to a party and people asking you, oh, what have you been doing the last few months? Oh, I've been getting cancer treatment. We don't want to do that. So we might then become detached, and we might be emotionally numb or just disengage in life because it feels safer for us. So I know we had some activity in the chat, which I cannot get to because my
No,
hand is
we're all good in the chat.
okay, good. Okay, good.
Yeah.
Just making sure. Yes, all
Yeah.
of the above. Thank you for checking all of the above. That's a great validation for me as well. So I do want to take a moment to that in the cancer and trauma business, we definitely talk about these three different concepts: activating, triggering, and re-traumatizing. And I bet a lot of you have heard words before like trigger warning, maybe on some content you're watching. Maybe you see, I was just watching a show the other night, and the next episode coming up said this episode contains content about suicide. And if you're feeling this, that's a trigger warning. Why are these things important when it comes to talking about trauma? And why do we need to understand what's different? When we're activated, I like to say that's when the hair on the back of my neck is standing up. I'm sensing something's not quite right, and I might not be safe. And that we may feel in that moment when we're activated, similar to the way we did when we might have experienced a trauma before. So let's go back again and think about that car accident. I have been in a car accident, which is why it's so close to me to use as an example. I am activated every time I get in the car, every single time. It's been 5 years. It changed me immensely. And what triggers me? Again, like just long drives, people tailgating me, things like that. They're heightening my emotions and they're bringing me back to a space that I was not safe in. So it can be things that remind us. I always like to ask people to tune into their senses, whether it's smell or sounds or touch. Those things are very, very important at triggering, at sensing, giving us a sense that we are triggered in that moment. What we really want to do is to avoid feeling re-traumatized. And this occurs when we are exposed to people, places, events, situations, environments that cause us to experience the trauma as if it were new again. And I think this happens, Sophia, so beautifully recaptured by you when you talked about the re-traumatization that happens at these various points across what it's like to be a Hodgkin survivor and the
It
things.
does. And
Mhm.
and sometimes the trauma isn't even cancer specific. It could be infertility as a
Correct.
result. So
Yes.
it's or a cardiac issue. So it's not specifically another cancer trauma, but it's related to the treatment.
Right.
Christina, I just wanted to add there's a comment in here by Diana. Perhaps we all need to go to the survivorship departments at our local cancer hospitals and propose they add PTSD follow-up care as well. Do you want to comment on that or?
Well, first of all, I would like to say, one, I wish there were more robust survivorship programs than there are.
Yeah.
I still think that we have a problem because everything is related to reimbursement, and it's hard to get paid for routine survivorship care. What though does that mean down the line? I think we're spending more money because our survivors are not doing well, rather than spending the money up front. I like to talk about the front end and the back end. If we
Yeah,
spent more money on the
prevention
front
versus, yeah.
end, maybe we would be better off, and I don't think we attend enough. And that's why the title of this talk is so perfect. We attend enough to the mental health needs of survivors. I think we know more about how to handle some of the physical symptoms, but I don't think we've done enough to manage some of these mental health challenges that are coming up for survivors. Excuse me. So yes, I do agree that that would be a great space. And Sophia, what are you doing in that survivorship clinic space?
Oh, so what we're doing in my research, and I'm going to talk about this later, with the 477 survivors of blood cancers who received a transplant. So they all have PTSD, and we're applying interventions. But long story short, what we found was one item on a PTSD measure that was strongly predictive of cancer-related PTSD. So I had my colleague and I at Sloan Kettering, and I had a call with Michelle Reba, who heads up the NCCN distress management panel. And based upon our publication, we're working to add in that item to the distress thermometer. Now, I have to say it's political.
Mhm.
It's going to take some time. So we're going to have to advocate for it. But that's what I wanted to tell everyone about: the awareness, the fact that clinicians, a lot of our clinicians don't even know about cancer-related PTSD. But if we can get this item added, now only about 50% of cancer centers use a distress thermometer. Other centers use like PHQ and some of the other ones. But at least we'd have about 50% of the centers screening for PTSD. So that's an example of where the research can inform clinical practice. The biggest issue is this all takes time.
Yes. And I did see Rachel's question in the chat about re-traumatization causing panic attacks. Absolutely. And I think it's important for us to understand. I think a lot of times when we have a panic attack, we're thinking, what are the things that made this happen? And I don't think we're oftentimes naming that I've been through stuff. I've had trauma. I'm feeling re-traumatized. That's what's causing this panic attack in this moment. I think a lot of times when we think about panic, we think about fear. Well, what are we fearful of when we are dealing with being a cancer survivor that may trigger something like a panic attack? And being painfully aware of our time and how quickly it's
Christina,
going.
this is great.
Yeah.
You're doing a great job. This is
Thank
all
you.
so important.
I'm so glad that we could have this conversation. It's so meaningful to me too.
I can see why you won the Leukemia Lymphoma Society Lifetime Achievement Award.
Thanks for that
It's
plug. So let's think too about what are some of the symptoms of trauma. And actually, I think this was a great feed in when we're talking about things like panic. Because panic is all of these things. It's emotional, it's physical, it's cognitive, it's behavioral. But what are some of the symptoms that we see of trauma that are emotional? Things like, again, anxiety, fear, guilt, anger, irritability. And that can affect us feeling safe or comfortable, also in advocating for what we need in care environments. Trauma may show up in our bodies in ways like fatigue, intense muscle tension. I'm feeling it right now in the entire right side of my body, which I find very interesting when I think about, again, my car accident. I was hit and I was hit on the left side, but all of my symptoms are on my right side. So and it shows up when I start thinking about it. So that's how I know it's related to that trauma that I experienced. It can also be things, again, like those sleep problems that we talked about. Maybe our hearts feel like they're racing and we don't really know why. Or another place I hear a lot of patients say it's coming up is my stomach feels weird. I'm flip-flopping. My guts feel like they're being ripped out. I'm in the bathroom every 5 minutes because my intestines are displeased, and there's nothing else physical that's causing that. It could be the trauma. When we talk about cognitive symptoms, what's happening in our brains? Difficulty concentrating, thinking negatively, feeling confused, and again, having flashbacks. And I again would love to hear in the chat if you're comfortable, if any of you have had flashbacks to specific places. I've heard patients who've talked to me many times about smells triggering flashbacks.
Yeah,
And
big time.
I
Smell
know
is
from,
the
yeah,
primary
from working,
primary trigger
I
of all the
remember,
five senses.
yeah, I remember when working on the floor, I knew what I still know what stem cells smell like. And it
Wow.
takes me right back to the times of working when I worked on the inpatient unit. So
You know,
smell.
Christina, I was 16 when I had my radiation. I still remember the smell in that room where that
Hmm.
linear accelerator was. We've got some comments in the chat. Can you see them,
Wonderful.
or do you want me to read them to
Yep,
you?
I'm looking at them now. So,
Diana's looking for tools.
okay.
And
I'm
yeah,
going
we
to get
do.
to tools.
Yeah,
Diana, hold on. I'm going to get to some tools. And I do want to
yeah.
just preface this by saying also, I am not going to tell you to take a bubble bath. I'm not going to tell you to smell essential oils. I'm going to tell you have to do a little bit more difficult work. I do think meditation and grounding ourselves is an important part of that as well. So I think that's something that will be important. But I differentiate this a little bit from what I think popular culture calls self-care. I think those things are self-soothing. I think we have to do a little bit more work in order for it to be something that can help us in spaces where we're feeling the results of traumatic stress.
Yeah.
Um, and then I see Diana, I propose to other cancer patients that they throw out any items in their home that remind them of their cancer treatment after they finish this. I think that worked for you, Diana. That is awesome. And I think that helps you to kind of have that control back as well to saying, this is out of here. And that can be something that's really helpful too. Andre, yes, emotional flashbacks, so fierce. Rachel, I hate ice cream. Oh, you, taking it with your chemo pills, I'm sure that brings you right back. And I had therapy for PTSD using ACT. Yes, U.S. Army. And ACT is definitely a treatment modality used a great deal for folks who are going through PTSD. Yes, the smell of the elevators. ACT is acceptance and commitment therapy. It is, again, a modality that is used by some psychotherapists. And I am not an ACT therapist. I would say I'm more of a meaning-centered type of person, but they're definitely related. Oh, the smell of Purell. Absolutely. Coffee, because that was
I
my.
I have comments too on the treatment modalities. Are
Yes,
you going to
please.
get into all those,
No, I
Christina,
wasn't
or do
going to for this, but if you
Okay,
want to,
yeah.
yeah,
So yeah, there are multiple, and
yeah.
a lot depends on the type of trauma.
Hmm.
And it's best to
Yes.
talk to a mental health provider, a social worker, psychologist, psychiatrist. I'll tell you what we're using. We're using cognitive behavioral therapy in our trial, and we're seeing moderate to strong effect sizes in our interventions. It's very effective. But again, it doesn't work for everyone. There are other modalities. Prolonged exposure can be added to the CBT. We developed a mobile app with the National Center for PTSD for cancer that we're using in our trial, which has relaxation exercises, mindfulness kinds of stuff. There's also EMDR, eye movement desensitization. I don't know what the
Yeah.
R is. That
Somebody
helps
put that
some
in the
people.
chat too, Sophia, about
Yeah,
that
yeah.
EMDR.
Um, did you want to talk about EMDR, Christina? You might be more
I
familiar with
mean,
it than me.
I'm still on the fence about EMDR.
Yeah, I
Um,
know.
to be honest, I'm still trying to learn more about it. And one
Yeah,
of my close friends is actually undergoing EMDR right now. And I'm just
yeah,
like, and I really truly believe that there isn't one specific way to treat trauma. As
Mhm.
again, this is something you want to do in partnership with a psychotherapist or a clinical
Yeah.
social worker. This isn't something, again, when we got on, and I'm sorry, I'm blanking on your name, but you were talking about the therapist who recommended a book to you. I'm not going to say that there's a book for you to do this. It's just way more complex. There are things that you can do to regulate and to help manage your symptoms of trauma. But when it comes to psychotherapy, you really need to do that in partnership with a skilled clinician. And those
Yeah.
are some of the things I would look at, like what are the modalities that you work in?
Mhm.
I'm big into narrative medicine. I like folks to feel comfortable with telling stories or journaling and writing their stories and then using those as a space to guide the therapeutic experience. There's so many different things that you can do. And you also have to find, really what works well for you. I want to make sure getting everything in the chat. And I thank you to Andre, who's saying that the EMDR is helping you tremendously. I'm so glad. Acupuncture is, I think, another great place when we're talking about the whole mind-body experience, right? I mentioned to you guys that I have all of this muscle tension. Well, what's something that might help me with muscle tension? Movement, massage, and progressive body relaxation that might be done during a body scan with meditation. So there's a lot of things that can happen simultaneously as well. Definitely holistic in nature. There's not just one magic bullet. Okay. So just wanted to spend a minute or two because I want to get to the meat. Like, what do you guys do? Remember that you might be experiencing some of these as well. And these are common responses to trauma: fight, flight, freeze, fawn, and flop. And maybe you've heard these. I'm sure that most of you have heard fight and flight. Freeze and fawn are sort of newer to our lexicon, and flop is definitely kind of the newest that is still being studied. These are ways that the body is trying to protect itself when it doesn't feel safe. They're automatic. We don't actually really plot them out. They are just happening in ways that we are trying to make ourselves safe in a situation. So I know, like, a lot of times people, when I say fight, they're like, patients getting upset, yelling. We like to say this is like the trauma Karen. Maybe that's what's happening, but they're doing that because they don't feel safe in that moment. Another space that we're really seeing that is in social media. And people are taking to social media all the time to air their grievances about their healthcare experiences. And that for me is also a trauma response. Something is not working with their healthcare experiences, and they're taking to a space where they feel safe to let it be known. Flight may be exactly what it is. I'm out. I'm getting out of here. I cannot manage this situation. Freeze, we disassociate. With fawn, this is where we are placating the thing that makes us feel traumatized in order to feel safe. And so a lot of times these are folks who, maybe you're the patient who, when the tech says, are you comfortable when you lay down for radiation? No, you're not. But you don't want to be a problem because you don't want to be labeled a certain way, or you don't want to have somebody work harder so that you feel comfortable. And so you fawn, you placate them, and you're like, yes, I'm fine. And flap is really, again, this newer one that we're still studying. That's really, it's like the next level of freeze. You're not just dissociating, you are completely and totally unattached to what is happening in the situation. Your body is completely limp. And this is the only way that you're feeling safe. Think about the possum who is playing possum. That's a flop response. Does everybody know that? Everybody knows what I mean when I say playing possum, right? I'm just reading the chat. Thank you for whoever, Sue, who wrote about art therapy. I love that. I've always been very, very much a proponent of activity in ways that we do things with coping. I did a lot of that work when I did bereavement work. I felt that action in grief was really important in ways that we could help to understand what we were going through at any moment of time and how we can actually turn that into something tangible. So I think that's really important as well. I'm also a doodler and I love art and I love to draw, though I'm not very talented in any way. So what's trauma-informed care? And again, I mentioned at the beginning, this is really my bread and butter space, but this is the first time I've done this and talked about this with patients. Trauma-informed care is a model that we are using in healthcare. It's not that new. But I certainly think that COVID helped to elevate it, because I want us all to think about what is COVID. It is a trauma that every single one of us went through, every single one of us. And it may have looked completely different. For some people, it didn't mean a thing. It wasn't any kind of change whatsoever to their lifestyle. They still went to work. They still went grocery shopping. They didn't wipe their groceries off when they came home. For some people, maybe a lot of the healthcare workers that you might know and have come into contact with, it was every day feeling threatened, feeling scared about going to work, fear of exposure, fear of resources, fear of the fact that we didn't have enough PPE to keep our healthcare workers safe. For others, we were not working, or we were working differently, or we were caring for aging parents, or we were homeschooling our kids. All of us went through it. And so I think as a result, we've seen a sort of a tie to more emphasis in this space with trauma-informed care. So what is it? It's a universal standard of care where we assume everybody in the medical environment that we are working with has some sort of a trauma history. Just like we assume all blood products are potentially infectious, trauma-informed care wants us to say all of these people that we are encountering in healthcare environments have some sort of trauma history. We don't need to know about it, but knowing that they might have something that they are bringing to the table that is going to affect their ability to have care, to be successful in their care, to be adherent to their treatment plans. We have to recognize that those things may be happening, and then we have to adjust the way that we work. And so it's not just a lens for how we as providers can improve how we take care of patients, but it's also a lens that you can use to care for yourself. So on this slide, you'll see that there are 6 pillars of trauma-informed care: trustworthiness, culture of safety, culture and historical awareness, collaboration, patient choice, and patient empowerment. I'm going to just spend a couple seconds defining what each of these are, and then we're going to look at each one about what are some of the things you can do as patients to apply these trauma-informed approaches to your daily life and helping to sort of deal with how trauma may be impacting your life. So trustworthiness is that you need to know what to expect and know that we as providers are going to follow through on the things that we do, that we say we're going to do. So it's really about transparency and communication and consistency in actions that build trust. The culture of safety is things like physical and emotional safety where you are going for your healthcare. But I want you to think about what might a culture of safety look like for you in your own home setting, in your community, and with the people around you who you would consider to be your support person. That safe environment, whether it's people or actually the physical environment around you, lowers your risk for re-traumatization and can make you more open to support and care. Our cultural and historical awareness, sorry, that was a funny little blub, is really understanding that trauma isn't just related to one thing. It's usually also deeply embedded in things like systemic racism, oppression, colonization, and historical or intergenerational trauma. Other things that have happened to us at other parts in our lives, we add another layer of cancer over it and or with it. So we have to be aware and sensitive of how our own culture and identity may shape our experiences, both as cancer survivors, but also as just people. Collaboration, how do we partner with others? Whether it is in the healthcare space or, again, as peer supports, what you are doing exactly in this space right here, this group is a trauma-informed collaboration. So kudos to all of you because you are doing the work right here. When it comes to patient choice, this is where we talk about getting back control, supporting your autonomy. So even small choices, or as I like to say, giving little nuggets of control back can help you feel like, hey, I am more of the bus driver right here, and I am able to say where we are going to be going. And patient empowerment is where we are focusing on your strengths. And I think when you made the suggestion earlier in the chat about bringing this to survivorship clinics and talking about screening for PTSD, that is a perfect example of patient empowerment in a trauma-informed space. So again, kudos, you're already doing the work. So safety, feeling safe can help your body and mind recover. So I want you to be thinking about, and Sophia and Aaron, I'm happy to share these slides with you all. I think you have them, but
Oh, great.
Aaron, I wanted to come back to your question and say, where would you put denial on that list? And and Rachel responded flight, and Sophia flight. I would agree. But I also think it could be in other places too. And I also forgot to say that you can be doing multiple of those trauma responses at the same time. And so sometimes it can be hard to differentiate when one starts and the other begins, but it is still a trauma response. And the other thing I want to acknowledge is that that is exhausting for us emotionally and cognitively and ultimately physically to be that like amped up, triggered in for a period of time, and having multiple or even one trauma response is a lot of work for us, for our psyche, for our brains. So let's go back to safety. These are questions you can ask yourself. Where do I feel most safe or at ease? And who do I feel most safe or at ease with? And what can I do in my daily life to increase my sense of safety? Safety is a really important value. And I do another exercise in a group and when I'm teaching called the values inventory. And safety has been on my values inventory for years. I've done this exercise for like 20 years. And never before COVID did I circle safety as being an important value to me. But in that moment, for the first time in my adult life, did that threat to my safety impact me enough that I really needed to think about how did I feel safe and where was I feeling safe? So it's an important thing for us to think about how that aligns with our values, if it aligns with our values. So one thing you might want to do, and again, this isn't about bubble baths and lavender, I like to say, but this is about doing some work. Identify one place or practice that helps you feel calm, grounded, and comfortable. So an example for me, yesterday I had a rough day. There was a lot going on. I was not feeling very in control of things. And of course, the Phillies are playing the Mets, which right now is a very difficult time for me because the Phillies and the Mets. But I was very amplified last night. And I said, I need to calm down. And the first thing I said was, I need to acknowledge my feelings. So that helped me feel safe. And then I grabbed my favorite blanket and my dog Dennis, and I was quiet for about 5 minutes because that's really all I needed to sit with him, pet him, and ground myself in a space that helped me to feel more calm, despite the fact that the day did not feel safe, did not feel comfortable for me. And sometimes we really do need to make the time every day, sometimes multiple times a day, to do that grounding to help us feel more comfortable. And that will align with us feeling safe. The next one, choice and control. Remember that small choices can help build up your sense of control. You don't have to choose to climb Mount Kilimanjaro tomorrow, but you might want to walk up the small hill in your neighborhood today. And that small choice says, yes, I can do this, and I'm feeling more in control of my choices. So think about what decisions are fully yours now, and how perhaps as a result of your cancer diagnosis, your treatment, the side effects you on, how have your priorities changed? I wrote that twice. So clearly that's important, is how have my priorities changed? And then what do? We choose one daily routine or activity where we get to set the terms. So whether that's I do something, I have a morning meeting with myself. And during my morning meeting, I have my coffee and I sit down and I plot out what my day, what I would like it to look like, whether it's tasks, meetings, presentations I'm giving, whatever it is. I really set the tone for the day. And again, that gives me a moment there to have choice and control over what's going to be happening at hopefully at points of the day. So then asking ourselves, how does setting those terms, which is retaking control, honor how our priorities may have changed? When it comes to trustworthiness, and Sophia, I might lean on you a little bit here to talk about the challenge of trusting yourself and your body again. When you've had an experience that your body has really maybe betrayed you. I hear many cancer patients saying, I did everything right. I exercised, I ate right, I was a vegan, I did this, I did that, I still got cancer.
Yeah.
And so, so I'm wondering, Sophia, if
But
you wouldn't mind, like, just
yeah, I experienced this personally. I was just telling one of my friends the other day that, one of the big issues for me was I felt like my body's betraying me. First, I got Hodgkin's, then I got breast cancer, and all these other late effects I'm dealing with. And I don't think there's an easy answer. I'll tell you how I cope with it. I've been an athlete all my life, so I make sure to get the physical activity in every day. But I'm sure there's, other people have other means. They may focus on their, getting their nails done or their hair done, or, what are the things that make you feel good about yourself? And I'm a big proponent of gratitude. Like when I was 16 and diagnosed, I used to pray to God, just let me live to be 50, you know? So uh, I'm sure everyone in our tribe here has an example of what they do to kind of combat that. I bet you most of us have had those feelings at
yeah,
least some point.
thank you for the validation of that. And I think that's like the space where I'm going to challenge you all to be paying attention to what your body and mind need. And again, that's work, especially if you're feeling like your body has betrayed you. But I love your activity, your example of activity and movement and exercise, but it's also things like, I need rest right now.
Hmm.
I know sometimes I feel guilty on days when I'm just feeling like I've hit a wall and I need to rest because I feel like I should be go, 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 do, do, do. But sometimes our body, we really need to tune in and pay attention and say, my body is telling me something. Maybe it's the connection and we need to go out with friends and be with friends. Maybe it's a way of nourishing ourselves. And I use the word nourishment. I didn't use food and diet and things like that because nourishment means a lot of different things to a lot of different people. I like to say, how do we fill our cups? And our cups may look very different. When we think about collaboration, this can be hard work too, because this has to do with some of the people oftentimes closest in our lives who may have abandoned us during cancer or cancer treatment. So it's important to ask questions like who has shown up for you, but also who hasn't? And have the relationships changed as a result of what you have been through? What do you need in a supportive relationship? And I think this is a very difficult one, but are you ready to let go of the non-supportive ones? I'm so glad that you have found, and Sophia, I'm going to use your language because you've used it a few times. You found this tribe of each other. And I'm getting the sense in my very limited time with you that you all feel very safe with each other to share your stories and your feelings with. So again, I'm giving you kudos because I think you're all very much collaborating with people who have shown up for you and continue to show up for you and continue to show up for the community at large, which I think is amazing.
Thanks, Christina. We're really trying to build that within Hodgkin's International. And one of the things I talked to Erin about was trying to encourage local meetups. I mean, the internet's great, online's great, but we've got a small group here in North Carolina and we get together every so often and it's really fantastic.
Mhm.
And we can compare notes, like
Mhm.
some of the questions being asked in the chat about
Yes,
anybody know a good therapist in Manhattan? Well, if we had a group a smaller group, they could share some of that information with. But anyway, we're working on it.
agree. And I think it's great. And I want to say yesterday I was over in the hospital and visiting a patient who is in my support group. And I walked in her room yesterday and I cried. And she's like, "Why are you crying?" And I said, "Because we've never met in person before. She was diagnosed with myeloma during COVID, and we've only ever known each other through the screen. So being with each other in the same room was a really different moment, especially, I mean, I was just having all these feelings yesterday as well, as I mentioned. So it was really nice in that moment to share with her. It's just nice to share space with you that isn't through a screen. So thank you, Sophia, for saying that, like local, when you're feeling safe to do that. And that's been a big issue for my myeloma group too, is feeling safe to be in person with each other when we're immunocompromised. That's just like a whole new world that we've had to think about as well. Going to move on to empowerment. This is seeking and seeing the resilience and skills and wisdom you have all learned along the way. And that is so, again, evident in this chat room here, in this chat box, that you all have incredible resilience, skills, and wisdom, which shows me incredible post-traumatic stress. So not only can you do hard things, you've done hard things, and you continue to do hard things. I have to remind myself sometimes that I can do hard things. And the other thing I say to myself a lot is my mantra is, what if you can? Instead of saying things like, what if I can't do this? This isn't in my wheelhouse. I don't feel comfortable. Sometimes I do ask myself things like, what if you can? What are the strengths that you know about yourself? Maybe things that you didn't see before you had cancer that can help you do those hard things. And so what do? You celebrate those big and small wins. So for all of you shouting out that EMDR is working for you, in the chat box, shout it from the mountaintops. That's empowerment. And then think about the question of, how does it help you to name those feelings? And then cultural and historical awareness. Our growth and our recovery are shaped by culture, history, community, and personal values. And so things that we can do are trying to recognize and honoring all of those parts. Somebody said intersectionality earlier in the chat, which is so important, how all of our parts. And then there's a whole other trauma and structural family therapy that talks about there's no bad parts. So how do all of these parts of who we are provide meaning, strength, and direction in cancer survivorship? So asking yourselves questions like, what traditions, values, or practices help you to understand your cancer experience? Identify a personal ritual to mark milestones. I know a lot of you have probably seen and or perhaps also rung a bell at various parts of your cancer experience. And while that is something that is very indoctrinated in a lot of cancer centers, we're also hearing from a lot of people they don't like that. But that doesn't mean you can't define what might be important to you and what might work well for you to mark milestones that are important, again, to you. And then asking yourself the question of, do I want to include my cancer experience into the larger story of who I am? And if I do, how? How am I going to do that? That's important. And you think about the parts of your identity, because cancer is part of your identity. So how do we put it all together? Think about trauma-informed care and growth in cancer survivorship. It's really important for us to feel comfortable with leaning into the idea that experiencing trauma after cancer is not a sign of weakness. It's a normal human response to a life-changing event. It's not just a medical experience, it's emotional, it's psychological, it's social. And our trauma can arise from diagnosis, from treatment, from uncertainty, from recurrence, from long-term side effects, even those follow-up scans. And so things like hypervigilance and anxiety, avoidance, re-experiencing are our body's way of trying to stay safe. And normalizing this, that's what we need to do with our survivorship clinic, can help to reduce the shame and stigma that you may be experiencing as cancer survivors. Remember, you're not alone. That's very evident from here in this group today. And recognizing that the impact of trauma is real, and so is the possibility for growth with that trauma. So understanding how holding both truths, that there's a struggle and the possibility of growth is a really big, important part of survivorship. So I think I had a few more. Cancer survivorship can stir trauma, triggers, and re-traumatization, but it can also open a door for healing and growth. Experiencing trauma or PTSD after cancer is normal and a common response for patient and caregivers alike. And by applying trauma-informed care principles, we can move forward with greater resilience. Trauma does not define the end of your story. And with compassion and awareness, you can find meaning, strength, and growth on your paths ahead. I do have some resources that I wanted to share. The first is a link to an article that I wrote on peer support programs that are available that lives on OncoLink. I'm also writing a whole bunch of trauma content for OncoLink. And if you're not familiar with OncoLink, it's oncolink.org. We are a cancer education website based here at the University of Pennsylvania, where I work full-time as the psychosocial content editor. And I write patient education materials. I use plain language. I use trauma-informed patient education techniques. And this is all, I'm so excited I get to do that work. There's also great resources with my other place that I work, in full transparency, with the cancer support community, which has network partners all over the country, a national helpline to provide support and resources. There's also SAMHSA, which is the Substance Abuse and Mental Health Services Administration, the Traumatic Stress Institute, which has a hotline list. And I would not be a responsible social worker with mentioning, if you are ever in crisis, to call 988 and to reach out for support. Today is actually Suicide Awareness Day. And
Oh,
so,
wow.
yeah, I heard that when I was listening to the radio this morning, and
Mm.
the DJ said, we never know what someone else is going through. And
Yeah,
that
absolutely.
really felt very resonant today as I was thinking about giving this talk. So I wanted to make sure that y'all knew how to access those
No,
resources.
that's
So,
great, Christina. And just a plug for SAMHSA, I know there were people looking for therapists. I know they used to have a search facility on their website, and you could search for clinicians that way. So give
and
that a shot.
I did post an
Wow,
article.
what a wonderful presentation. This was incredible.
Thank you. I
Thank you
did
so
post an
much, Chris.
article earlier about that I also wrote for OncoLink on how to find a therapist. And I just
Great.
wanted to say that I agree that finding a therapist, finding the right therapist is like doing a job interview for someone you are hiring. They're your staff. And if they aren't the right fit for you, you probably want to fire them.
Yeah,
So I think it is very important for us. That's a space to feel empowered in, right? And to also
yeah,
advocate for what you need as patients. So
absolutely.
definitely a good place to start. And I know that Carolyn Messner would be mad at me, Sophia, if I didn't mention for people in Manhattan,
Yeah.
cancer care as a great
Oh,
place to start
definitely.
as well.
Definitely.
First of all, I want to thank Christina. That was a fantastic presentation, as is evidenced by the fact that nobody's really left yet.
Yeah.
I'm
Most of,
overwhelmed by this chat. Everybody, thank you. This
no,
is
it's been great
amazing.
and clearly much needed. I know
Yeah.
Sophia has a ton of expertise in this area, has done so much research. So I want to spend as much
We
time as you can.
complement each other. I'm
I
the
know you do.
scientist, Christina's the clinician.
Okay, Sophia, you're on.
Okay, let's see if I can share my screen. There we go. Let's see, slideshow. So I'm going to go through this pretty quickly because there is some overlap. And this is what we say at the beginning of talks: nothing to disclose related to this presentation. So I want to back up a little bit because, whoops, I know a lot of us have concerns in mental health that aren't specifically trauma related, or maybe they're related to the trauma, but not specifically post-traumatic stress. So I'm going to back us up a little bit. I'm just going to go through these quickly just to kind of put trauma in a greater context with mental health, because I think all these components of distress have been experienced by most of us. So when we talk about distress, and the National Comprehensive Cancer Network has guidelines related to distress, and the distress thermometer instrument that many of us fill out in the cancer center is developed and maintained by this panel at NCCN. So they define distress as an unpleasant experience of a psychological, social, spiritual, and/or physical nature. And Christina touched on this earlier in terms of trauma as well. So when we talk about distress in the cancer world, we also include depression and anxiety in addition to PTSD. And as I said earlier, it's along a continuum. It may start at the cancer diagnosis or even before, and it continues on and on. So, how many cancer survivors are distressed? The literature suggests 20 to 60% at a specific moment in time. And again, Christina talked about PTSD. And when you ask the general public, well, who gets PTSD? The first thing they tend to say is, well, veterans of war. But there are other populations, Christina mentioned earlier, that are also at risk for PTSD. And she also talked about what are some of the symptoms: the intrusive, the avoidance, the arousal, and a lot of us are dealing with survivor guilt. And about 3.5% of people in the general population, whether they had cancer or not, would meet criteria for PTSD. So, what do we know? The science tells us that it's higher in the cancer population. So, what does the prevalence look like? So, we've studied this across different cancer types, different treatments. And if you take a look at the entire cancer population, about 10%, 1 in 10 survivors, would meet criteria for full PTSD. Now, to be diagnosed with full PTSD, you've got to have significant symptoms in all 4 of those symptom clusters we talked about. And perhaps the most worrisome to me as a cancer survivor are the avoidance symptoms. Because what happens is, to a lot of us, is that we don't want to go back to that cancer center for our follow-up care. Or we may even avoid doctor clinics, even primary care physicians in general, just being in a medical facility or smelling the alcohol or whatever, the wipes that they use, or getting blood drawn even, will trigger a trauma response. So I'm going to share with you a personal anecdote. When I was diagnosed with breast cancer in my 30s as a result of my chest radiation, I was treated here at Duke. My Hodgkin's was treated at Sloan Kettering. And after my first chemo for the breast cancer 20 years later, I remember getting nauseous and then throwing up and then having this weird experience. Like, it, I felt like I was back at the age of 16 and I was dealing with my Hodgkin's diagnosis when in fact I was really dealing with treatment for breast cancer. And it was such a strange feeling. It was like almost my mind was playing tricks on me. And I remember talking to a psychologist who was volunteering in the cancer center here at Duke, and he said, "Oh, that's re-experiencing. That's a PTSD symptom." So because of that personal experience that I had, it led me to include a measure in my dissertation study to assess lymphoma survivors for PTSD. And these happen to be non-Hodgkin lymphoma survivors. And I recruited 886. And these were survivors who were at least 2 years post-diagnosis. And what I found was fascinating because I followed them up 5 years later. So I studied them, I assessed them for PTSD, and then 5 years later, I went back to the same people and assessed them for PTSD. And what I found was that 1 in 3 had persistent or worsening PTSD symptoms. And that really launched my research program. What we also found was that those who were younger, so us, our tribe, AYAs, adolescent and young adult survivors, were the highest age, were the most at risk of all the age groups we looked at. We also found lower income, so people with less resources, and those who received a bone marrow or stem cell transplant. I'm going to mention caregivers here just so you're aware. A lot of us, our caregivers were our parents. We are seeing in the work we're doing at Sloan Kettering and Duke, we are seeing higher rates of cancer-related PTSD in the caregivers. The moms of the pediatric cancer survivors have the highest rates of PTSD than any other group studied. And I've listed a bunch of publications here. If any of you want to do some deep dives, if you can't get the publication, email me and I'll get it to you. Christina mentioned post-traumatic growth. I never give a presentation about PTSD without mentioning this. So, I was fascinated by the question, are they related? So, what do I mean by that? If someone has full-blown PTSD, does that mean they have low post-traumatic growth? Or if they have a lot of post-traumatic growth, does that mean they have a little PTSD? Perhaps post-traumatic growth is a protective factor. Well, the data from my 886 survivors say otherwise. The two are unrelated. What we found was no correlation between PTSD symptoms and post-traumatic growth. You could be high in both, low in both. One is higher, one is lower. All right, just moving on to depression. I just want you to be aware that these are very common symptoms of depression. And if you feel that you're checking off a lot of these boxes, then it would require follow-up with a physician or a mental health provider. And a lot of us, we don't have a survivorship clinic, so seeking some support from a primary care physician is a good place to start. And unfortunately, about 1 in 4 survivors experiences major depression. So again, we are at higher risk than the general population. And importantly, I want to impress this upon you. When we look at distress, when we look at depression, anxiety, PTSD, they're all highly correlated with one another. It's very common to have all three. So oftentimes you're not just dealing with the PTSD, you're also maybe dealing with depression and or anxiety. There's medications for this. We talked about counseling, cognitive behavioral therapy, ACT. Again, seek the advice from a mental health practitioner, and caregivers are encouraged. We encourage our caregivers to contact us if they're noticing suicidal thoughts in the survivor, safety concerns, if the survivor is experiencing panic attacks, trouble breathing, etc. Okay, the other symptom I want to talk about is anxiety. So what does the prevalence look like for anxiety in the general population? About 1 in 5. And there are different types of anxiety disorders: generalized panic, social, phobia related. You may have one, you may have multiple. And it can ebb and flow depending where you are in your survivorship journey. You know, Christina talked about anxiety. I mean, I'm so many years out and I still get anxious every time a particular MRI or mammogram or whatever test I'm having done. Fear of recurrence is, you know, it may be heightened within the first 5 years after a cancer diagnosis, but it never really goes away. It's like that sword of Damocles hanging over your head, you know, or what new late effect is going to show up. It seems like we're bombarded with new studies and publications telling us about some new late effect related to our treatment. Panic attacks are real. I've seen this in the clinic, and um, they can last a while. And you know, it's important to recognize that they're they're not uncommon. And again, like Christina said, they're not a sign of weakness, and it can be treated. Um, so, things you can do. Number one, discuss with your doctor, whether it's a primary care doctor, if you're fortunate enough to have access to a social worker or psychologist, um, get treated for it. Um, there's a lot of online support groups, local support groups, you know, American Cancer Society, Leukemia Lymphoma Society, and then, you know, focusing on your self-care, whatever that is. And I know I have to remind myself to do this a lot. But if we can just keep that as a priority, that's helpful. These are just some of my thoughts on therapy. Um, it's a safe space. The conversation's confidential. It should be about you and not the therapist, as we talked about earlier. And it's a process. It's not an immediate fix. It's an ongoing, you may be in and out of therapy depending on what's going on with your health or life in general. And you should find a therapist where it's collaborative, that they take your input and just not tell you what it is you should be doing. And so many people are in therapy now, and I'm especially encouraged by the younger generation who have really embraced it. So I'm looking at the time. Looks like I got a few more minutes. So this was a comment on my dissertation study. And it says the one thing doctors overlook is the emotional well-being of the patients. So this really gave me fuel for my dissertation. And back in 2005, I studied 886 survivors of non-Hodgkin lymphoma, and it was funded by the National Cancer Institute. And I followed them over time. And based upon our findings, I reached out to the National Center for PTSD to see if they'd be interested in collaborating and developing a mobile app together, which we did. And we ran a pilot study, and the results were good. And then we redesigned it here at Duke and made it available on the App Store and Google Play. And now we're studying it in a large trial, which is being funded by the National Cancer Institute. And I've got some wonderful colleagues. These are colleagues over at Sloan Kettering, and these are some of my colleagues here at Duke. And Eric is at the National Center for PTSD. These are just some screenshots of the app. We have a learn component where they can learn about PTSD, cancer-related PTSD, We have support. They can go in and search for therapists. We have an assessment. You can go in and assess yourself to see if you meet criteria for PTSD. And then we have this managed symptoms. So we have different exercises within the app to help, relaxation, audio, body scans, things like that. And we have the learn component where you and your family can learn about cancer-related PTSD, etc. So in our trial, we're in the 5th year right now, and we've enrolled 477 survivors who received a stem cell transplant. So they're mostly blood cancers. And what we do is we give them the app, and if they get better, great. And if they don't, we step up their care, and we either add a coach to the app or we administer a cognitive behavioral therapy protocol. And I'm presenting in Chicago at ASCO next month results of our trial, which our interventions are showing moderate to strong effect sizes in reducing PTSD symptoms, which is fabulous. And we were quite pleasantly surprised to learn that in addition to reducing the PTSD symptoms, the interventions also reduce depression and anxiety. So it's very encouraging for us, and it's showing us that with digital health technologies, mobile apps, and remote therapy, we can potentially move this right into the clinics. And that's what I'm working on next, submitting a large grant application to the National Cancer Institute on October 1st. So just some final thoughts. PTSD symptoms are prevalent and persistent. And if there's one takeaway I would love for you to have, is that they're very normal. And a lot of us are dealing with them, have dealt with them, currently dealing with them, or may in the future be dealing with them. We have mental health providers that can help diagnose and treat. And I get this question a lot: can I get your mobile app? So our mobile app is called Cancer Distress Coach. Unfortunately, it's not available to the public because we're researching it. We hope someday that it will be, someday in the near future. In the meantime, strongly suggest that you go to the App Store or Google Play and download my colleague's app, PTSD Coach, which our app was based on. It's free, and it was developed by the National Center for PTSD. And this is my fellow Tar Heel Stuart Scott. And I love this quote: when you die, that doesn't mean you lose to cancer. You beat cancer by how you live, why you live, and the manner in which you live. So with that, yay. Hopefully we have time for a Q&A.
Thank you so much, Sophia. That was, I mean, what an hour and a half or so. I feel like I'm traumatized by trying to
Do
take
we
it
still
all in.
have people? There's still.
We do have quite a few people.
Oh,
And I
good.
think